Welcome to AETCM, the emergency medicine channel. Today we are discussing about forced alkaline diuresis or forced diuresis. Forced diuresis involves the administration of diuretic agent, that is furosemide, and isotonic saline, that is normal saline or Ringer lactate, to increase the GFR, glomerular filtration rate, and urine flow. When this process is combined with sodium bicarbonate infusion, it is known as forced alkaline diuresis. This is done in many patients who had taken a toxic dose of certain drugs. So we'll see what is forced diuresis, forced alkaline diuresis, and one more term is forced acid diuresis. The mechanism of forced alkaline diuresis is the urinary excretion of some of the drugs can be increased by altering the urine pH, whether it is acidic or alkaline. So some of the drugs which are more acidic can be removed by making the urine pH into alkaline. Altering the pH converts a lipid soluble intact acid or base in the tubular lumen into the charged salt. This charged particle is lipid insoluble, and so that it will not be stored in the fat tissue, so it is becoming lipid insoluble and cannot easily move back to the body across the renal epithelium. This leads to a marked increase in the drug excretion. So remember that some drugs can be easily removed through the kidneys. When you increase the fluid intake and give furosemide, the urine output will increase, the drug can be easily moved out, more amount of drug can be moved out. If you make the urine alkaline or acidic, depending on the alkalinity or acidity of the drug, it also can be expelled faster. So that is forced alkaline diuresis or forced acid diuresis. Now we'll see what are the drugs which can be eliminated when you increase the urine output. What are the drugs which can be eliminated when you make the urine more alkaline? Poisons for which diuresis with isotonic saline, that is normal saline or Ringer lactate solution, may enhance the drug elimination are barium, bromide, calcium, chromium, cisplatin, cyclophosphamide, fluoride, 5-fluorouracil, potassium, isoniazid, that is a TB drug, lithium, that is an antidepressant or mood stabilizer drug, and thallium, tritium, all these things. In that, most important is lithium. Among this group, most important is lithium. Lithium toxicity is very common in emergency room. Isoniazid toxicity is not that common because the availability of drug is very rare. Lithium is very common. Whereas agents for which alkaline diuresis may enhance the excretion are, one is an herbicide, another one is chlorpropamide, that is not used nowadays. The most important drug in this group is salicylate and barbiturate. Both these drugs toxicities are very common. Both salicylate and barbiturates are common. Other drugs are sulfonamides, methotrexate, fluoride, diphenazole. All these things also can be removed by this route, but commonest drugs are salicylate and barbiturate. For all practical purposes, lithium can increase the lithium elimination can be increased by lactate, Ringer lactate, and normal saline transfusion. Alkaline diuresis can increase the elimination of salicylate and barbiturates. When we are giving large amount of volume, fluid and soda bicarb, there are higher chance of complication. To avoid that, before giving this transfusion, we have to take the basal levels of electrolytes. Most important is potassium, because when you are giving sodium bicarbonate, there will be high chance of hypokalemic complications. Blood urea nitrogen, creatinine, because if the patient is already having renal failure, anuria, large amount of volume may produce complication. Blood sugars, blood pH, urine pH, baseline blood pH and urine pH is required. Drug levels of certain drugs, like a patient is already on some drugs, we have to get the drug levels. All the patients who is undergoing this forced alkaline diuresis should have a Foley's catheter to know what is the urine output for the measurement, intake output measurement. Forced alkaline diuresis is contraindicated in patients with renal failure, pulmonary edema, or any volume overloaded condition, and patients who is having cerebral edema. There also it is contraindicated. Complications of forced alkaline diuresis are hypokalemia, that is the most important complication, excessive alkalemia, ionized hypocalcemia, which results from increased protein binding of calcium. So hypocalcemia and hypokalemia are one of the most common adverse effects of forced alkaline diuresis. That most important, most common is hypokalemia. So to prevent that hypokalemia, we have to give potassium chloride. 20 to 40 milliequivalents can be given in initial time itself. Otherwise, patient can have hypokalemic complications. Now we'll see what is forced alkaline diuresis. Forced alkaline diuresis, you give fluids, you give Lasix or furosemide, you give sodium bicarbonate and increase the alkalinity of the urine so that you can remove the drug through the urine. The goal of urinary alkalinization is to achieve a urine pH more than 7.5 while maintaining serum pH not more than 7.55. We should not keep the serum pH very high. So increase the serum pH so that you can increase the urine pH. We need a goal of more than 7.5 in both urine and serum. This is done by, this forced alkaline diuresis is done by giving IV bolus of 1 to 2 milliequivalents per kg of 8.4% sodium bicarbonate, followed by continuous infusion of sodium bicarbonate. So this is sodium bicarbonate is given along with fluid. The dose of sodium bicarbonate is 1 to 2 milliequivalents of milliequivalent per kg, 8.4% soda bicarb. Then continuous infusion of sodium bicarbonate. The fluid for continuous infusion is mixed by placing 150 milliequivalents of sodium bicarbonate into 1 liter of 5% dextrose. That is, so we have to, initially we have to give 1 to 2 milliequivalents per kg as a bolus dose. Then 150 milliequivalents should be diluted in 1 liter of 5% dextrose water, that is DNS. After the initial fluid resuscitation with normal saline or Ringer lactate, so we have to give for normal saline or Ringer lactate initially itself, 500 ml bolus can be given. Intravenous bolus of sodium bicarbonate, that is we already explained. The sodium bicarbonate continuous infusion should be given at the rate of 200 to 250 ml per hour. The rate should be titrated based on the urinary and systemic pH, which should be monitored throughout the therapy. IV fluid should be adjusted to maintain a urine pH more than 7.5 and serum pH of less than 7.6, and we can increase the serum pH to 7.5 to 7.6, but it should be less than 7.6. Now another terminology is forced acid diuresis. Forced acid diuresis, which is very rarely used nowadays. The role is only explained in severe acute amphetamine toxicity, quinine toxicity, fenfluramine toxicity, fencyclidine poisoning. Here 500 ml 5% dextrose with 1.5 gram ammonium chloride is added, followed by 500 ml 5% dextrose and then 500 ml isotonic saline at an infusion rate of 1 liter per hour. The urine pH to be measured at half an hour interval and ammonium chloride added to the second 500 ml of 5% dextrose if the pH exceeds 6.5. This is not used nowadays, but only for theoretical purposes I have told it. Forced acid diuresis. So we have explained what is forced alkaline diuresis, where it is indicated, how to give it. So when we give this large amount of volume, we give 500 ml initially normal saline, then we give continuous infusion of, then we give soda bicarb, then we give continuous infusion of soda bicarb with 5% dextrose, we give Lasix, we have to give potassium before this drug is given. So all these things is having higher amount of fluid and higher amount of salt. So if the patient is already having a volume overloaded condition, like somebody is having cardiac failure, liver failure, nephrotic syndrome, there is a high chance of pulmonary edema in this patient. So they should be very closely monitored in ICU. Without close monitoring, we should never give post alkaline diuresis. So one of the most important toxicological treatment for many drug poison. Thank you.